speaker is Arantxa of Roca from Malaria Consortium.
Okay, thank you very much. And I would like to talk today and present our experiences on implementing some of the cross-border surveillance and malaria post-screening surveillance activities that we have implemented in the Greater Mekong sub-region, particularly in Cambodia, focusing specifically on mobile and migrant populations. And I believe some of the key lessons learned and experiences, particularly from an operational point of view, are particularly relevant for other countries or regions that are considering incorporating malaria screening or cross-border posts as part of their malaria elimination activities. So just to give a brief background on why the importance of focusing on mobile and migrant populations in the Greater Mekong sub-region, or the GMS. As you know, in that particular region, and there is high heterogeneity of transmission within the countries, but also between countries in that region. And there is this high interconnection of mobility. As you can see from this map, there is this the labor migration flows are very dynamic. And that really, in a way, poses a particularly important threat of likely importation of infections, particularly in countries that are closer to achieving malaria elimination goals. And also the mobile and migrant populations, communities, they are considered one of the high vulnerable groups for malaria infections, mostly because of poor access to health facilities or services, but also poor access to potential prevention methods for malaria transmission, but also because of their economic or occupational activities, which really will get them closer to either the infection because of they are forest goers, because of they are closer to the forest, or because of their type of occupation that will actually request them to be more exposed to outdoor biting, for example. So it is within this kind of complex dynamics that we find ourselves kind of trying to see where those mobile screening posts or cross-border posts might be best placed and located. So it is very important that our ability to capture these complex dimensions and interconnections of mobility and characterizing these subpopulations of mobile and migrant populations before, in order to interpret the results, but also in order to optimize the way we implement those screening or mobile malaria posts. So there is clearly a need to provide a better understanding of how cross-border or mobile screening posts could be implemented and also introduced. And as with any other health event or epidemiological event, as an epidemiologist, one of the key questions we want to answer is trying to really look at the key 5 W questions: the what, who, where, and all those questions somehow will try to kind of address some of the questions, at least partially, based on the experiences of 2 cross-border malaria projects that we have implemented together with the National Malaria Control Program in Cambodia and with the collaboration of the Institute Pasteur in Cambodia. So we had 2 sets of projects, one that started in 2013 till 2014 and looked at 3 different international borders for Cambodia with the 3 neighboring countries, and also a follow-on study in one particular border, the Cambodia-Laos border, from 2015 until just 2 months ago, September 2016. And trying to look at some of the where questions, it was important for us to look at where will be most appropriate to establish those border malaria screening points, and whether we could quickly identify some specific hot borders. And I think it's just important to highlight at the time we were thinking about those questions, it was mid-2013. It was at a time where the K13 molecular marker had been discovered. It was at a time where there was a lot of discussion on what will be the proportion of asymptomatic infections potentially crossing the border or kind of spreading potential artemisinin resistance, and at the time where there was a clear characterization of what sort of levels of subpopulation of mobile migrant activities were happening in the fringes of Cambodia. So with that context, we we looked at the 3 international borders, what you can see from the map. The yellow one represents the screening post that we set up in the Cambodia-Thailand border. That was the Cambodia-Laos border, and the blue one represents the border post for between Cambodia and Vietnam. And basically, as you can see from the pictures, it was relatively simple setup. It was just a basic tent, a table, a couple of chairs. The staff involved were actually already the mobile migrant workers, or the village malaria workers, together with some support. And basically, it was a voluntary participation. So people that agreed to participate into the screening activities completed a semi-structured questionnaire. We also collected documented temperature, and a blood sample was taken to conduct a rapid diagnostic test, a combo test, and the real-time PCR through a dry blood spot. So just moving quickly to some of the results, this table represents the proportion of positive infections based on both the RDT and the PCR, and it's quite a busy table, and it's already published data that you can go for further details, but wanted to kind of particularly focus on the PCR results from the 3 borders. So it was kind of just from the first few months of data collection, it was already quite obvious that there was one border that was particularly high in showing very high positivity rates of around 12%, and it was the Cambodia-Laos border. And one of the follow-on studies that was, maybe just quickly important as well, there was a lot of risk factors that were characterized and a lot of information, but also one of the key elements was a very poor kind of levels of knowledge on how to prevent against malaria in the same particular border where highest positivity rates were obtained. And it was very important to kind of ensure that there was an active deployment of BCC materials at the Cambodia-Laos border to kind of encourage higher levels of knowledge, attitudes, and practices. So moving into this follow-on study in that particular border, we knew that an international border was a convenient place, but there was a lot of discussions about what will be the best optimal location. There are clearly an international border is just an arbitrary line, and there are many other ways of actually crossing that particular area, either because there are nearby villages and they constantly cross for groceries or market, for example, but there are kind of unofficial borders in the sense that there are kind of natural paths where people might cross, of course, the official borders. So we wanted to really look and try to compare whether there were significant differences in the risk profiling of the MMP subpopulations and see whether there were also significant differences between positivity rates within those groups. So we set ourselves to identify certain unofficial and informal and compare it with the international border. The green one represents the official international border in the Cambodia-Laos. And the red ones, those are unofficial borders. There is a nearby village, which is very close to the forest, and there is a natural path where people will actually go through that village to go to the forest. There was a specific criteria for selection of those unofficial borders, and it was a combination of the existence of police in place to facilitate some of the activities, recommendations by the provincial authorities, as well as safety considerations. This is the map showing the positivity rates observed by the different border points, and again, the international border shows similar positivity rates compared to the first project that was conducted, and there was a much higher positivity rate in 3 nearby unofficial borders, really twice showing a 2-fold increase of positivity rates, almost even going to 35% positivity rate. But again, I think what everyone will be wondering is like, well, what this relates to. I mean, who are we talking about? Who got a screen? And I think, again, that's one of the key important questions that we also need to be able to answer, as like how biased was our sample? We know it's a convenient systematic sampling, but who was actually getting a screen? And we saw a relatively high proportion of refusal rates. Clearly not everyone that is on the move would like to stop and get tested. And it was about between 20 and 30%, and that kind of varied by border. But I think it's also an important aspect to really highlight the importance of sensitization and also the importance of harmonizing activities if we have two neighboring countries. And that was actually a project that was only implemented in the Cambodia side, but it was very important if any activities is to be implemented at a wider scale, that there is a very clear harmonization and communication between the two borders, so that the sensitization and acceptance of activities are accepted. Just showing, some basic demographic characteristics on who actually got screened, the majority being males and adults, which is one of the key kind of high risk groups for being positive, and not surprising that the majority were from Cambodia, as the screening path was in that Cambodian-Lao border. Just the same type of graph showing the positivity rates within those specific subgroups, and showing that the highest positivity rates were observed into the males and adults. And also, perhaps interesting to show that despite the numbers really being small, the nationality of this other beyond Khmer Lao was showing a high positivity rate. And once we kind of quickly looked into the data, it was mostly coming from construction workers coming from Vietnam. So getting all that information and setting up a quick risk profiling will actually guide and help kind of follow-up activities on where best to kind of deploy certain response activities. So just again, briefly highlighting that as a tool, it was kind of effectively capturing the high-risk group of mobile migrant populations being adult mates. Moving into occupation type, and we know there were a lot of subpopulations of different occupations that will pose different populations at higher risk. And some of the key very high risk groups were actually found to be the forest goers and the construction workers, showing really high positivity rates. And in a way, I think that's important to bear that in mind, because the positivity rate that you will find will be highly driven by these economic and occupation type activities. And in a way, it will not be driven by the normal rainy season patterns that you would expect. And this is in a way shown that positivity rates were not really necessarily aligning with the highest rainy season, but rather by other factors. And perhaps also to point out that just within 2 or 3 months of data, you will be able to identify whether that's a particular hot border that you want to look in or maintain, or whether that's an area where you probably don't want to maintain any screening. Looking into where they were coming from, we looked at information about the origin, the transit, and the destination of those border crossers. And again, this is just a basic heat map kind of summarizing the clustering of that event, of where place of origin and where they were coming from in the initial travel. And not surprising, again, that most of the travel will come from the same province we were actually setting up the post. But I think it's also very important that it's quite a high proportion of people coming from different areas. And when we are going to set up specific activities, pre-departure, BCC activities, it's also important to look into the origin. And one of the other aspects that we looked was the travel history. Where exactly were these people, they've been in the previous weeks? And that's an element where we really struggle. It has been really an operational challenge to actually capture that information and being able to translate it timely into information that will guide us a specific location for follow-up and investigation. And I think there is also a lot of work potentially to kind of simplified the methodologies for having perhaps landmarks or put-it information so that the location of the travel history gets easier and more systematically reported. Moving into questions that were particularly interesting for us, it was really looking at the differences between symptomatic and asymptomatic, and what was the difference between what the information was given through the PCR data versus the rapid diagnostic test that was considered a point of care at that time. And this pie chart basically shows that out of the 2010 people that got screened throughout the year, 400 cross-borders were positive, and roughly 50% were found to be symptomatic, and 50% of those were found asymptomatic. And the distribution of the species for both symptomatic and asymptomatics based on PCR was relatively similar, a higher proportion being Vivax, small proportion, around 10-15%, of falciparum, and much higher proportion, a slightly higher relative proportion of mixed infections in the asymptomatic pool. And we wanted to compare that to what we actually found based on the RDT result. And as I said, it's a combo RDT test. And this is just another way of presenting the data. This is a Venn diagram, again with the pink circle highlighting the total number of symptomatic cross-borders that we found. And if we look at the shaded circle, it's actually the total number of PCR positives. So all those numbers will add up to 400. What I found particularly interesting is this smallest circle is what was the ability for the RDT to pick up positive cases. And in a way, just as a summary, just only 1 in 3 PCR positives was actually being picked by the RDT, but most of those were coming from the symptomatic pool. So we were really struggling to actually find asymptomatic infections through the RDT. And if we look at the species breakdown of the RDT positives based on the PCR data species, again, we are talking now kind of small numbers, but 2/3, 66%, were found to be symptomatic, which is basically this area. And again, a relatively high proportion of Vivax and kind of similar proportions of falciparum and mixed infections. What I found quite interesting is that this third, this small pie there, the breakdown was quite different. We had a much smaller relative proportion of Vivax, again, not being, and a relative increase of relative proportion of falciparum infections. We also have a false negative RDT cases and mixed infections. So in other ways, the ability for the RDT to actually pick up the asymptomatic, particularly Vivax infections, was really low, which really points into potentially the need of having these high sensitive or more sensitive point of care diagnostic tools for these kind of proactive screening activities. So just summarizing a bit of the kind of conceptual process, it was really about understanding the basic epidemiology that already we had in place, and kind of starting with these 5W questions and trying to see whether there was some sort of evidence-based information to guide the location of those screening posts. Once that information is available, we do kind of potentially full risk profiling of which are the subpopulations that we are particularly dealing with in that area and context, and kind of digesting that information to really guide the analysis and the interpretation. Is that a go, no go? Is this relevant for setting up a mobile post or not? What are the risk factors that could actually help to do a risk screening tool to guide reactive case detection, particularly of co-exposed, if we have a combination of risk factors for that particular subgroup? And again, linking that information so that the information that we have has improved, which I think has already been pointed out by Arnold, is really about kind of making sure we close the circle, the information circle, from data collection, data interpretation, and decision making. But yes, we did find certain kind of important challenges and operational considerations that it is touched on them already, but it's important to remember, like, we need a full understanding of the refusal rates, who were we missing that potentially biased our results, and understanding the coverage of those screening activities. A need for flexibility at all levels. For example, we found ourselves not identifying any people crossing the border, and we realized there was a new road and the flux of people were kind of using a different route. So the ability of having a very simple mobile post or structure that could easily move into the right place is very important. So that level of flexibility is key. The choice of diagnostic for that particular first proactive screening to do the full risk profiling is really important. And the importance of harmonization of both sides of the border. Tracing travel history, identifying proxy locations and landmarks will become one of the key elements that we would like to focus on and improve. And just looking at programmatic factors, there were all other operational aspects, like when exactly to screen. And we compare the different timings at the different days. It was kind of much higher probability of identifying infections during a weekday and in the afternoon as people were coming back from their activities. So those considerations are important if we really want to kind of optimize the way we implement those posts. And of course, tracing changes in movement. And I think that's a unique opportunity for those posts to identify and keep on updating what actually is happening in terms of major construction or development activities that might guide rapid movement of populations. With all these considerations, we could really improve a risk assessment tool and potentially kind of optimize the way we identify infections. So just my last slide, really to point out that this activity is potentially useful, of course, to kind of provide early detection and treatment to mobile and migrant populations. But in isolation, it really loses the value. It is really important that it is kind of fully integrated into a full, the full surveillance system, so that it really timely triggers a potential response to really go into full active investigation. And this is one of the kind of key next steps that just started 2 months ago with the new grant, the ICC-RAI, to ensure that there is a full rapid response based on the information that is being collected in those border posts. So making sure that the screening posts not only provide this passive, routine, early detection and treatment and potential interventions such as BCC to the border crossers, but also guides reactive case detection activities and response activities. And I think that's the importance of ensuring this integration of different platforms. So with that, I would like to end, and would like to thank particularly for CNM, Dr. Puli and Dr. Siv, that has been really very supportive from the beginning on the initial stages and up to the end of this project. I would also like to thank Didier Minard from the Institut Pasteur for making sure all the PCR data was really coming timely. And of course, everyone from VMW's mobile malaria workers, health facility staff, and of course the MC staff in the country that really supported and made it happen. Thank you.